السلام عليكم. معلش انا بعتذر، هي طبعا مقارنه بالمحاضرات اللي شفناها هتبقى فيري بورينج لانها يعني كلام كله نظري شويه، لكن انا هحاول يكون الموضوع يعني مش بمستوى طيب. هو our patients, as we know, the venous disease accounting for about 10% of our population, and most of the patients come in the category of clinical presentation like C1 telangiectasia or C2 like B and C varicose veins. The patients also may come with C3, which is edema, C4 like E and F, which is skinny changes, C5, which is healed ulcer, and C6, which is active ulcer. Regarding the anatomy, as Dr. Wasila mentioned many times, the great saphenous vein might be treated, the small saphenous, the anterior saphenous vein, I corrected, the posterior axial saphenous vein, and sometimes we see the non-saphenous varicoses, which are mostly countered in the anterolateral aspect and the posterolateral aspect of the thigh, and as we heard, usually it's associated with pelvic venous disorder. The American Venous Forum published in the year 2020 the appropriate use criteria for treatment of chronic venous lower limb, and they mentioned that it's appropriate to treat the truncal reflux of the great saphenous vein in patients complaining of C2 to 6, even without saphenofemoral junction reflux. They also mentioned it's appropriate to treat below the knee great saphenous vein in cases of C4 to 6. And they mentioned that it might be appropriate to treat great saphenous vein reflux in patients complaining of edema, taking care that the edema might be of another cause like cuff muscle dysfunction or lymphedema. And the famous EVRA trial, the English trial that studied treatment of venous ulcer in patients, the investigators reported that the patients who had early intervention had better outcomes regarding median time to heal and rate of ulcer healing and ulcer-free time in patients who had early intervention in comparison to patients who have deferred interventions. They didn't talk about specific type or specific modality of treatment, yet most of the cases were done through foam sclerotherapy with or without thermal ablation. So our inventory for treating these patients starts, of course, with the thermal, which is the golden standard now for treatment of varicose veins, the radio frequency and the laser, also other types like cryo, steam, or microwave, and the non-thermal, non-tumescent techniques, the cyanoacrylate, the MOCA, and the foam sclerotherapy, and of course, the surgery will have its place all the time. For the cyanoacrylate, the WAVES study studied treatment of small saphenous vein, anterior saphenous vein, and large saphenous veins even reaching 20 millimeter, and they reported occlusion rates reaching 98%. Yet the great saphenous vein diameter more than 8 millimeter was a strong predictor of recanalization. The V-close, which is the Turkish glue study, it was a multi-center RCT studied non-inferiority in comparison to radio frequency, and they studied more than 200 patients, and they reported occlusion rate reaching 94%, even more than the radio frequency, which was 92% in the study in 36-month follow-up, and they continued to report better results in 5 years. The occlusion rate reached 94% in almost 40% of the patient without reporting any major adverse events. Several systematic review and the meta-analysis showing statistical significance difference. There is no statistical difference between the technical success in the cyanoacrylate and the thermal techniques. Of course, there is complication. The post-operative complication after cyanoacrylate are limited. Mostly are described as phlebitis, which reached about to 20%, but in most of times it's transient, benign, and self-limiting. And the definition of hypersensitivity to cyanoacrylate was reported up to 7% of cases, but mostly was mild. Other complications reported like DVT, superficial venous thrombosis, hyperpigmentation, exercise infection, hematoma, even nerve injury, but nothing exceeds 6%. That's why the European Society for Vascular Surgery recommended the use of cyanoacrylate to treat the truncal reflux if a non-thermal, non-tumescent technique is preferred. For the sclerotherapy, the known material used for sclerotherapy are polydocanol or STS. They might be used for truncal ablation or tributary treatment. They could be used as foam, which is better than liquid regarding efficacy and using less drug. And it could also be available as the ready-made microfoam by Boston. The comparative study treatment, the famous one that Dr. Rashad mentioned, done by Rasmussen, he compared radiofrequency, endovenous caesar ablation, modern surgery, and ultrasound-guided foam sclerotherapy. The foam limb was inferior to other groups regarding occlusion rate. Even more, the efficacy was worse when the great saphenous vein was more than 6 millimeter in diameter. But the quality of life scores in this study showed even patients that had lower occlusion rate had improvement in the quality of life measures. And even that, the investigators used the foam sclerotherapy even for recurrence in other limbs. The foam sclerotherapy has the advantage that it could be used when other modalities fail, as it has no problem regarding access site and failure of advancing the ablating device. Another type of foam sclerotherapy is catheter-directed foam sclerotherapy, which is introducing a catheter inside the vein for 30 or 40 centimeters. And of course, it's ultrasound-guided. And a systematic review and the meta-analysis recently studied about 3,600 patients showed that occlusion rate is higher with catheter-directed foam sclerotherapy, 80%, versus the ultrasound-guided foam sclerotherapy, which was 63% in a 3-year follow-up. The complications of foam sclerotherapy might be local, like transient hyperpigmentation up to 15%, like mating up to 10%, superficial venous thrombosis up to 14%, and other thromboembolic events like DVT, which is really scanty. It's less than 0.6%, and they are really related to high doses of foam, above 30 millimeter of foam injected. Remote complications like neurological events in the form of visual disturbances, headache, and migraine, transient ischemic attacks also were reported, but they're very scanty and with no serious sequelae. And this happens in cases of right to left shunting. And that's why symptomatic right to left shunting conditions are absolute contraindication for foam sclerotherapy. And the fact that patent foramen ovale is present in almost 30% of normal individuals, yet we don't have to search for before foam sclerotherapy. And the European Society of Vascular Surgery recommends the use of foam sclerotherapy may be considered in veins, in great saphenous vein less than 6 millimeter, and it always must be under ultrasound guidance. And the catheter-directed foam sclerotherapy may be used with or without tumescent anesthesia. For the mechanical occlusion with chemical assistance, it acts through a dual injury mechanism. The mechanical injury of the disruption of the intima of the vein with the chemical ablation by the sclerosing drug. Two devices are available right now, the Clarivane, which is basically a little hook stick wire that is rotating to injure the vein, the intima of the vein, and then a liquid sclerosant agent is injected. And the other device is the fibrograph, which is a catheter with a sharp hook sticks inside the vein, inside the catheter. It injures the intima of the vein, then a foam sclerotherapy is injected. For the Clarivane, randomized control trials compared MOCA to the thermal ablation and found it's safe and efficient. The 3-year follow-up reported occlusion rate up to 86%. One RCT showed that the MOCA is inferior to the radiofrequency and the endovenous laser ablation, having occlusion rate just 80% versus 100% for the thermal ablations. Another trial showed that occlusion rates for grade 7 vein diameter 6 and 7 and 8 were 887% and 75%. Another trial showed that the revised venous clinical severity score and the quality of life measures have no significant difference between MOCA and the other modalities, and they showed improvement in all studies. The pain during and after MOCA were less than radiofrequency and were equivalent to the endovenous laser group, and the return to daily activities and work didn't differ between all the procedures. The complications were in the form of induration up to 18%, superficial venous thrombosis up to 13%, DVT up to 1%, hematoma to 11%, hyperpigmentation 5%, nerve injury, skin injury, or infection have never been reported in MOCA treatment. For the phlebograph, only one study showed 92% occlusion rate at 48 months. That's why the European Society for Vascular Surgery recommends the use of mechanical chemical ablation if a non-thermal, non-tumescent technique is preferred. And this scheme will just to wrap up what I have mentioned now for patients, I think Dr. Gawi showed it many times. The grade 7 vein truncal reflux, the gold standard is still with thermal ablation. Class of recommendation, the first one, and grade of evidence is A, followed by cyanoacrylate, which is class 2A with level of evidence A. Then MOCA, class of recommendation 2B with level of evidence A. Then foam, class 2B with level of evidence B. And for the tributaries, only the foam sclerotherapy could withstand with phlebectomy. Thank you.